Hello, everyone, and welcome to a new episode of Home of Medicine podcast. My name is Ben Lovell, and I am a consultant working in London. You should know me by now. And of course, my wonderful co-podcaster is...
Hello, welcome. I'm Dr. Amie, a consultant in acute and general medicine working in the UK.
Right, Amie, it's my turn, and I've got a case for you. All right, so pen and papers to the ready. This is the story of breathlessness. Not neurology this time, you'll be pleased to know. This is a 46-year-old woman who came in through the medical take complaining of breathlessness. And the breathlessness has been going on and getting worse for 6 weeks leading up to this presentation, and particularly terrible the last 2 nights. And on reflection, she says, actually, now we're looking back, probably my breathing hasn't been quite right for 4 months. But I really noticed the start of a deterioration 6 weeks ago, and the last 2 nights I haven't slept a wink because I just feel breathless all the time. And she's gone from having unlimited exercise tolerance to struggling to manage 5 minutes on the flat without having to bend over, grab her knees, or lean against a wall and pant and gasp to try and get her breathing under control. She's not sleeping. She's breathless really badly overnight, and particularly at the end of the day. Although she denies very clearly orthopnea. She can lie flat very well. It's not making a difference at all whether she's flat or sitting up on pillows, but she just noticed that's the pattern of it. But she's never had any cough or sputum production during any of this. It's just really, really breathless. And this is a fit and well woman usually. She works on her feet all day as a social worker, so she's moving around a lot. She has a bit of gastroesophageal reflux disease, but she manages with Gaviscon every now and then. Her GP told her she might have blood pressure problems on a couple of previous readings, but no firm diagnosis, and she wasn't taking any medication yet. And yeah, in fact, her drug history was 0, so she doesn't take any meds. She's never smoked. She does drink alcohol very occasionally, but certainly not in a regular fashion. And I was very struck when I met her that she was breathless. She was working hard. When I walked into the cubicle to see her in A&E, she was actually standing up next to her bed saying, I need to stand up here because I just can't catch my breath. And her SATs were 91 on air. I had to put on 5 liters of oxygen to get her SATs up to 99. So breathless and hypoxic, which is important. Her blood pressure was elevated, 197 over 91. This is a woman who's probably on the verge of getting a diagnosis, hypertension anyway, but it also is acutely unwell. So that adds another 30 points to your systolic. Her respiratory rate was about 25, and effortful, I would say. And her heart rate was 78. So I went to listen to her chest, expecting to hear something, but her chest was absolutely clear. So no wheeze, no crackles, no added sounds at all. She was afebrile, and I assessed her for heart failure because that's the 2 first things I look for breathless people. Has something wrong with your lungs? Has something wrong with your heart? But she had no pedal edema. JVP was completely neutral. She had no crackles in her lungs, as I mentioned. The only thing really of note on the examination is she has a high BMI. She says she's put a bit of weight on recently, especially around her middle. But she was working hard to breathe. So that was my initial introduction to her. What flashes up in your mind encountering a sort of patient like this, and which way would you turn next?
Okay, so I just keep going, PE. Does she have a PE? Is there multiple PEs? Is there pulmonary hypertension? That sort of thing's going on in my head. Secondly, I'm thinking she's 46, so young, and it's been happening for around 4 months, you say. So has there been any other type of symptomatology? I'm starting to think about any joint diseases, any skin tightening. You said she had dyspepsia. I'm thinking really weirdly systemic sclerosis, pulmonary hypertension. So I'd want to know if there was anything like that. When I think of breathlessness, I guess you can think about it in, is it a lung problem? Is it a heart problem? Is it a mechanical problem with the lungs? Is it a mechanical problem with the heart? She's hypoxic as well. So does she have any pets? Is a question.
No.
So,
Why?
and I'm thinking about, like, does she keep pigeons,
Why?
alveolitis, extrinsic allergic alveolitis? But
You
then,
know,
but
we
then
don't
you,
call it that anymore. It's changed its name, Amy.
what's, remind me, I did.
Hypersensitivity pneumonitis. So we've carbon dated ourselves there. But when we were at med school, it was called, you're right, extrinsic allergic alveolitis. But hypersensitivity pneumonitis was your query. But no, no pigeons at home. She has not got pigeon fancy as love.
Okay.
That would have been a cool
Um,
diagnosis.
does she take the oral contraceptive pill?
She doesn't. Why?
So I'm just thinking of PEs. Is she on a combined oral contraceptive pill? Because I often find when I ask patients, do you take any medication? And they say no. And then if you ask them specifically if you take the contraceptive pill, they say yes.
Mm,
Because often patients don't see it as a medication, it's just a contraception.
mm.
Um, so what I've written down here was ABG, PETS, OCP. So I guess
ABG first. I mean, for me, that was exactly my thought process as well. I was like, oh, hello, nice to meet you. You have a PE. That's the, if someone's got hypoxia and a clear chest, that's the first place my mind goes, because PEs don't make any noise. They come like thieves in the night. Now, and I was going to do a CTPA, no two ways about it. And
Mhm.
it's a straightforward one, just to mix it in a little. I didn't ask for the D dimer, but it got done. And it was 310, which is low.
What's the cutoff in your hospital? Because our cutoff is less than 0.5.
I think we multiplied that by 100. So it's 550.
Oh, so it's negative then, in
Yeah.
essence.
Yeah.
It's
Yeah. Yeah.
low.
Yeah.
Okay. Oh, okay. Which I guess the D-dimer is also an inflammatory marker. So it's sort of saying to you that there's probably not an infection there either. With that, interesting.
Because
Okay.
normally we're moaning about positive D dimers, which is messing with
Mm.
our thinking. But here's a pesky little negative D dimer. When we kind of want it to be positive to fit in with what we want. So my question to you, have you ever seen anyone with a PE and a normal D dimer before?
Once. Yes, I have.
Me
Once.
too once. Me once in 19 years. Yeah, yeah, yeah. So
Yeah,
rarely.
once in 19 years. It might have been the same patient, unlikely, but yeah, once in 19 years, and I'm still shocked by it now. I'm like, how?
Yeah,
But that's once in 19 years have I
yeah.
seen a negative D-dimer with a PE.
So the negative predictive value of the dimer is incredibly high. It is such a powerfully useful test. And a negative dimer normally stops you from progressing further towards either doing a Doppler if you're looking at the leg, or a CTPA if you're looking at the lung. In this particular case, I had no alternative diagnosis. And I did the CTPA because I was like, could this be patient number two who I'm seeing in my career, who somehow escaped the power of statistics and the negative predictive value? So I did progress to a CTPA, but I thought it was interesting that it was a weirdly negative D-dimer, which is normally a very, very useful test to rule out
Mm,
and to stop you advancing towards imaging when you're worrying about a venous thromboembolism.
yeah, yeah.
So just to let you know, the ECG, normal sinus rhythm, nothing fancy on it, no S1QT, T3, no right heart strain, not even a sinus tachycardia. These are the common things you see associated with the PE. Sometimes you get some subtle ST depression or a T-wave inversion, but no, it was normal sinus rhythm. And a chest X-ray was completely clear. She had a hiatus hernia we could see, but otherwise there was no focal consolidation. So we get the CTPA. We have an interesting conversation with the radiologist who wanted to, give us a little nudge about negative predictive values of D dimers. And I said, I appreciate where you're coming from here, but I really, really want this CTPA. CTPA is done, no PE, no
Okay,
consolidation, collapse, or any other issues, but no PE. So clearly this lady is not going home because she's hypoxic and she's on 5 liters of oxygen. So my plan is, number one, admit to ward for oxygen therapy. That's the easy bit. Then it gets a bit weird. Number two, I'll say, okay, VTE prophylaxis, that gives me 2 points, but now I've really got to put my money down and do something intelligent here. So what would be the rest of your plan at this point? Unexplained hypoxia.
I've just had a thought which is completely wrong. I've just wrote down CO2.
Yeah.
Has she? What you're describing is like an air hunger. Is that? Is she like gasping for breath, or is it like
She
a
wasn't
breathless?
gasping. So you mean like Kussmaul's respiration,
Yeah,
when
but
people are desperately trying to neutralize a metabolic acidosis by
yes,
blowing off CO2.
that's what I'm thinking.
Yeah. So that's kind of like a sighing respiration when you see it. It's like,
Mhm.
but she was more like gasping, like she's just done a 50-meter sprint. We did do
Okay.
an ABG actually because I wanted to see what the CO2 status was. I wanted to see, and her ABG, which was on oxygen, on 5 liters of oxygen, showed that her pH was normal. So it's
Okay.
7.37. Her PCO2 was normal at about, well, normal low at about 4.9. And her
Okay.
PO2 on 5 liters of oxygen was 17. Which was
Oh,
appropriate for oxygen therapy,
yeah.
electrical oxygen therapy. Basic cess, lactate, they were normal. So the ABG didn't reveal an interesting metabolic acidosis or respiratory acidosis. It showed what we already knew.
And the kidney function was normal?
So kidney function was completely normal. Her CRP was 2.1. Her full blood count was completely normal, including normal neutrophils. Yeah. And a troponin was done, which was 12, which is normal where we are, less than 14. So all the blood tests came back with none in red, all completely in normal limits. And it's funny because the differential diagnosis at that time, which I'll put my hand up and say, yeah, I wrote it, was unexplained hypoxia, which is not a diagnosis, but that's all I had at the
Well,
time. So that's what we went with. So
you're right, though. I
oxygen.
mean, she is hypoxic and it's unexplained. So
Yeah.
again, we're trying to thinking about we've got massive amounts of uncertainty here. So when you've got that breathlessness, I keep thinking, is this something metabolic? Like it's not really infection, neoplastic drugs. She's taking any drugs over the counter. She had any diet pills that she's taking over the
No,
counter.
no.
What's the diaphragmatic nerve like? Does she have diaphragmatic nerve palsy?
I'm going to say no. Okay.
It's a stretch.
Yeah. So diaphragmatic failure, that puts you into type 2 respiratory failure because you
Exactly. But just
hypoventilate. So yeah.
yeah.
Um, I mean, the only thing I had to go on was she was quite overweight and she did have a hiatus hernia, but those are both chronic issues that shouldn't
Mm.
have given her 2 nights of really gasping for breath and a quite subacute onset hypoxia. Those are things that might predispose you to breathlessness and maybe chronic type 2 respiratory failure, obesity, hyperventilation syndrome when you have a very, very high BMI. But that wasn't really satisfying me as a diagnosis. So I admitted the only other thought I had was while she's here, we'll get an echo. I
Okay.
don't think she's got heart failure.
Mm.
Has she got some kind of intracardiac shunt? For example, if there was a PFO, which had reversed flow, or some kind of ventricle septal defect, and she was mixing oxygenated and unoxygenated blood, and that would maybe
Rising
be causing it.
syndrome.
Well, if she'd Eisenmeger's, that means she would have to be born with a congenital heart disease, and now finally she's reversed her flow.
Exactly.
But she wasn't clubbed in her toes or her fingers, which I remember we had to look for Eisenmenger. So, but I said, we'll
Yes.
bring her in for an echo and we'll see what things are tomorrow. Again, like we say a few times on this podcast, I don't know what it is now, but I know how to correct the individual pieces of it. So I can treat hypoxia till the cows come home with a bit of oxygen. That's easy peasy. And I think we can keep you safe tonight. But at the moment, I haven't got a reason why you are breathless and why your oxygen levels are a bit low, was how I framed it to her. So she comes
Hmm.
in. So the next day, she gets her echo. Great for her, but frustrating for me. It was completely normal. So there was no, it was not a great quality study because of her body habitus. So they didn't get fantastic images. And they said, look, if you really want us to rule out shunting, she'll need a bubble echo study. But based on what we've
Okay.
done today, the heart biventricular function's normal. There's no pulmonary hypertension. The valves all look fine. Um,
Okay.
so we good IVC respiratory variation. So we can't. There was nothing. There was nothing. No red flags coming out of the echo at all. And I saw the patient again. She'd weaned a little bit from 5 down to 2 liters of oxygen, but she was still oxygen dependent and she was still breathless. And I said to her, and the way I phrased it is, we don't know.
Mm.
Because we're still working on this, but we don't know. And it was the weekend, and I said, let's see what you're like on Monday. And she said to me, is there a chance you will never know what this was?
Mm.
And I said to her, I have seen patients in my career where they become unwell and they can get better again and they go home and we all just say, wow, what was that? And it never comes to light. And that is unbelievably frustrating. It's
Yeah.
frustrating for us too as doctors, but it's really frustrating for you because you want to know why you're not well. So I said there is a reality in the future where that does happen, but we're not done with you yet. But
Mm.
she was just getting a bit frightened at that point.
Hmm. So you kept her in overnight, and you overnight she'd oxygen had decreased. Did you do any other management?
No, just oxygen. Any other bright ideas before I go on?
Is she pregnant?
You always ask that.
Oh, wow.
She, well, she could be. She could be at 46. She ultimately is not pregnant in this story, no.
Okay. Because I've been caught out once, you see. And it's one of those things, isn't it, where you have like that hindsight bias where yeah, anyway. Okay, so I'm stuck, to be honest. I've thought about we've talked about shunting, we've talked about pulmonary hypertension, infection, trauma, metabolic conditions, drugs. Enlighten me, Ben. I'm a bit stuck.
Fine. So I ordered a test which I never order on medical inpatients in the acute medicine world, and that's inpatient lung spirometry. And the reason I never do spirometry is because you shouldn't do it when someone's acutely unwell, because you get weird results. If you did spirometry on someone who's in the middle of a COPD exacerbation or pneumonia or something like that, you're going to get very bizarre results, which does not represent what's going on with their lungs on a normal day-to-day basis. But in this case, I thought spirometry might be useful. I thought it might be useful to see whether she had an obstructive or restrictive lung defect or none of the above. And she had inpatient spirometry. I'll quickly run through the values, but then I'll tell you how we interpreted them. So her FEV1, so the amount of air she blew out in 1 second, was only 1.6, which is 39% predicted. And an FVC, so vital capacity, was 2.6, which is 50% predicted. And that gave her an FEV1 to FVC ratio of 54%. Now, and a ratio of 54% or 7% or lower is obstructive. And our obstructive
Mm.
lung defects are really a small airways disease. So COPD, asthma are the main ones. However, there was a restrictive element to this. Her
Mm.
FVC was not normal. Normally, with an obstructive defect, your FEV1 goes down whilst you do maintain a normalish vital capacity. So it takes you a long time, like 6 seconds plus, to get all the air out, but you get there. So she had a dropped FEV1 and an FVC, but the proportions they were dropped, the FEV1 was way more dropped. So the ratio came out. So it's a little bit, it was obstructive, a little bit restrictive, if that sort of makes sense. And I thought, well, the restrictive aspect of it probably was a little bit of obesity. And when we talk about restrictive lung defects, we're talking about what's restricting the lungs from opening, like a beautiful concertina or an accordion, opening up and closing again. Something's restricting it. And if it's an intra-lung restriction, such as fibrosis, so stiff architecture, a stiff accordion that won't open, or is it external to the lung restriction, such as a massive kyphosis if you're bent over, or if you've got a lot of soft tissue because of obesity, so you can't open up your accordion. So I thought I can explain the restrictiveness, but I can't quite explain the obstructive picture. And the key to this actually meant going back to radiology. We had a CTPA when she came in and we asked them a question. We said, is there a PE? And they said no. We went back to the radiologist with a new question. And we said, is there any evidence of small airways disease on this study? And they kindly discussed it at their lung radiology MDT. And they said there is evidence of mosaicism of the small airways in keeping with small airways disease. And mosaicism just means that when you look, it looks like a mosaic, little tiles of black and white. And it's a little patchy change, which you see in asthma. So going back with that new question, they came back and said, yeah, there's actually good radiographic evidence for small airways disease. CT evidence of small airways disease, obstructive defect on the spirometry. Is this all asthma? Adult onset asthma? She wasn't wheezing, which is atypical. She didn't mount an eosinophilia, but you don't have to. And in fact, with adult onset asthma, it's much less likely to be allergic, to be eosinophilic than childhood asthma. This would be a new diagnosis. So we went back to the patient and we gave her 40 milligrams of pred and QDS salbutamol nebs. And wow, what a difference. The next morning, she said, I've had the first night's sleep I can remember in a long time. My breathlessness is much, much, much better. We did some peak flow measurements and she clearly was dropping her peak flows in the evening overnight. Going back to the history, she said to me in the evenings overnight, that's
Yeah.
when the breathlessness is so bad. She had that diurnal variation. And her
Yeah.
peak flow was 400, which was 66% of predicted. So a little bit of, and we started on Foster. Foster salbutamol nebs. Foster is a combined in ICS and a lab inhaler. So Foster, salbutamol nebs and pred, and she recovered really well and weaned to oxygen very, very quickly. And I think this was a patient with a very atypical presentation of adult onset asthma, complicated by a high BMI, complicated by quite a nasty hiatus hernia, which was causing a bit of local compression. But I think this is what was presenting. It was small airways disease, and she responded to treatment. The plan is to follow up with repeat spirometry and a respiratory outpatient clinic appointment. But I think we nailed the diagnosis in this case. And the interesting thing for me is radiology are looking at insanely complicated scans, and they will answer the question you ask them.
Yeah. Yeah.
And that's why we have to be so careful when we put questions down on our reports. And that's why radiologists get irritated when you write down things like request CT lung, query pathology. Well, what do you want me to look? What am I looking for here? You have to tell them what your question is. And sometimes if you change your question, you get an answer because they'll redirect their focus and their technology on answering different questions. And sometimes that can reveal something new. So a lot of responsibility for getting good detailed, nuanced results from CT scans comes from us, the requesters, and putting good information down. Good data in, good data out.
Yeah,
There you go.
absolutely. Yeah. Wow, really interesting case. Do you know, at no point in my thought process did I write asthma.
Neither did I up and for a very long time.
No, which is a really interesting learning point for me. What I did write was some really rare stuff. And I guess maybe it's the acute physician in me. I'm like, it must be a PE. She's coming to hospital. It must be a PE. And I think sometimes it is about taking that step back. And actually, when you go back to the history, a PE doesn't last for 4 months, that breathlessness with a PE, does it? It's interesting that she wasn't wheezy, that her chest was clear. And I would have probably expected somebody who has such severe asthma that warrants admission to hospital with hypoxia, there would be some, bronchoconstriction that would cause a wheeze. But yeah, what did you do about the blood pressure? Did the blood pressure come down?
A little bit. It was still high on discharge, 180/90, but I don't manage that. Blood essential hypertension is, to me, is an outpatient diagnosis and management plan. We've learned, and there's good evidence to this, that if we start messing around with treating it as an inpatient, we do harm, because the patient goes home, gets over their acute illness, relaxes, has a cup of tea, does the crossword, and their blood pressure goes down to 80/40, and they fall over and get a subdural hemorrhage. So this should be managed in the patient's own environment by a general practitioner, and this is well within their bread and butter. They know what they're doing here, and I think the interventions we make when a patient's acutely unwell, in pain, afraid, sleep deprived in a hospital can cause real repercussions in the long term. I think it's the hobby horse we've jumped on before in this episode.
It is, and I'm completely agree with you. It drives me potty when we manage an isolated hypertensive blood pressure in hospital in a patient. What I do sometimes tell people is, you've had high blood pressure in hospital. Oh, it probably is related to your admission. However, you could check your blood pressure twice a day at home and do like a blood pressure diary, rather than starting them on inappropriate medication. But instead of just ignoring it, depending on the case and what's been going on, I do suggest maybe you could do a blood pressure diary.
And that's reasonable.
Yeah. Yeah, and a lot of people do check their own blood pressure now. They check they can come and show it on their phone. They're like
Mhm.
they've got on their watch, it's linked to their phone, and they've checked their blood pressure and everything. And I'm like, wow, the technology is incredible.
Well, you can get a little things you plug in your phone which will tell you your heart rhythm as well. Have I told you the
Yeah,
story about years ago in ESTEC in ambulatory care? I said to a man in his 60s, he said, "Hello, why have you come into it?" And he said, "Oh, my phone sent me a message saying I had to come into hospital because I'd gone into atrial fibrillation." And I looked on his phone, it had detected that he'd gone into new AF, printed out a rhythm strip and texted him. I was like, well, clearly I'm redundant. This is the future of healthcare. Goodbye, job. All they need now is another program in the hospital dispenses a blood thinner and a bisoprolol,
exactly.
then cut out the middleman and I'll just stay at home and eat pizza. Very
That's where AI will come in, Ben. And what
yeah.
will be really interesting is if I looked on AI now and said, um, what I'm trying to, you got shortness of breath in a, how old she was 4. So,
46.
yeah, so I
It
wonder if
should
it would
say,
come
"I'm
up.
not giving medical advice, please see a physician." Otherwise, they're
Yeah,
in legally dodgy ground.
yeah. So, what are your takeaway points in this case?
My takeaway points are, we've said it previously, I think in the previous episode, you don't have to make the diagnosis on day 0. Sometimes the patient needs vitamin T, which is a bit of time, and then the diagnosis suddenly sits up and starts singing on day 1, day 2, day 3. And I would say my main point is the radiology answer you get is based on your question. So if you don't get an answer which makes sense, you can ask a different question if you've changed your approach to a patient. And it's not somehow rude to go back and say, "Hey, can you have another look at this scan?" You're not saying, "I don't think you did it right the first time." You're saying, "We've actually changed our clinical question now. Could you have a look at it from this point of view?" And sometimes that reveals something really useful. That's why we have these MDTs, radiology MDTs, in so many departments, so you can sit down. It's great for training and education, but it's also for discussing these images contemporaneously with the clinician there who's got the patient story and the questions, and the radiologist there who's got the ability to interpret the images for us.
Yeah, absolutely. And just an update, I did just search on AI. What are the causes of shortness of breath in a 47-year-old female? Number 1, respiratory infections. Number 2, asthma.
Oh no.
I know.
Oh
We
well,
are we are
it's a good
absolutely.
ride. It's a good ride while it lasted.
Yeah, exactly. I mean, I'm not telling everybody to not no longer listen to the podcast and just use AI. However, I think there is a use of AI somewhere in medical practice. I just haven't quite figured out where it is yet. But I'm sure
Okay.
in our lifetime it will be used more. Um, Thank you so much, Ben.
Thank you very much, Amie, and thank you for everyone for listening to the podcast. I hope you're enjoying these and how we work through these sorts of things. I hope it shows you that we have to sit down and concentrate just like everybody else. Consultants don't know all the answers like this. And hopefully it just makes it a bit more explicit, our thinking process as we move through different diagnostic conundrums. And maybe it'll help you in the future if you come across similar scenarios, or even just our ways of thinking you could apply in other places. We love it when we hear feedback about the podcast, either via email, or you can tweet us both. We're very easy to find on the app formerly known as Twitter. And if you want to leave us a review on Apple, that's fantastic because it helps more people find our podcast as well. So thank you very much for listening. Thank you, Amie. And we'll see you next time.
Thank you very much, Ben.